So the viruses, we will talk about again the viral characteristics. What are the specific diagnostic tests and the serological tests to diagnose the viruses? And finally, what is the viral classifications and what are the important ocular virus pathogens? So what are the viruses? The viruses are acellular. So in contrast with the bacteria, they doesn't possess a cell. That's why they require cellular material from other organisms in order to replicate. That's why it is called an obligate intracellular parasites. So a parasite is an organism that cannot live by its own and they need other living organism in order to survive. And the virus is a parasite because it needs to enter inside a cell in order to replicate, and it is obligate. So it has no option. So living or not living, that is the question. The virus will enter a living human body or living tissue like animal, like plant or any living tissue, and it will survive inside this tissue. If it is present outside the tissue, it will die in maybe in few hours. So what is the basic structure of the viruses? So we said that the virus doesn't have a cell. So what does it consist of? First of all, it will consist of the viral genome. The viral genome, or the nuclear material of the virus, can be either a DNA or RNA. So for the living organisms, it is a DNA nuclear material. But for the virus, it can be either a DNA virus or an RNA virus. This DNA or RNA or the viral material, viral genome, will be enclosed with a capsule. This capsule or this shell is called the capsid. This capsid is a protein shell that will enclose the viral genome. It can be different in shape. It can be helical. It can be hexagonal. It can be cuboidal. It has different shapes, but at the end of the day, it has the same function, that it will enclose the viral DNA or RNA. Then there is an envelope. This envelope, it is a live protein envelope that will enclose the capsid. So these are the basic structure. First, the viral genome, DNA or RNA, surrounded by a capsid, surrounded by a viral envelope. So as you can see, the cell, there is no cell here. The viron or the virus is very simple in structure. It is just to have a genetic material surrounded by a capsule. So that's why the virus cannot survive by itself. So it needs a living tissue in order to survive. That's why it's called an obligate intracellular parasite. So the living cell. The first of all, the virus, like for example, let's say for influenza virus, or as we are now living in the era of coronavirus, let's say it's a coronavirus, it will, in fact, it will first attach itself to the host cell. So the first cell the first stage is called the adsorption. It is simply that attachment of the cell to the wall of the host cell. After this, the cell or the virus will be included inside the cell, or what's called penetration. So the fusion between the envelope of the virus and the cell membrane will lead by endocytosis. The virus will be engulfed by the cell or will enter inside the cell, and now the cell has the virus inside it. So what happened now? Then the virus remove its capsid, or the virus has a capsid that will protect the nuclear material. So the virus will do what's called uncoating or capsid removal in order to remove the capsid and allow the nuclear content to enter inside the cell. This is followed by that the virus will control the nuclear material of the host in order to reproduce a viral DNA or viral RNA. So if there is a viral, if there is a DNA virus, then the virus will target or the nucleus of the cell of the host, and will control the enzymes in order to make a messenger RNA for the virus. In order to, this messenger RNA will form the viral DNA. Again, the viral DNA, if there's a DNA virus, it will control the nuclear material of the host cell in order to form a messenger RNA, in order to replicate the viral DNA, so that it will be now it will fuse with the capsid again, and it will be released outside the cell, forming a new virus, and this new virus will infect another cell, causing a more viral replication. So the DNA virus will produce intranuclear inclusions. The nucleus here have the nuclear matter or the nuclear material, or the DNA virus of the virus, so it appeared as intranuclear inclusions. This is not the case with the RNA virus. So the problem with the RNA virus is that we don't have, or the living tissue doesn't have RNA. So how can the virus replicate itself? So for the RNA virus, the replication does not occur in the nucleus, but it occurs in the cytoplasm. So when the virus, like the retrovirus of the HIV, attached itself into the cell by endocytosis, it will penetrate inside the cell. So it will undergo uncoating, so the capsid will be removed, and now we have the viral RNA. So how can this viral RNA will replicate itself into copies inside the cell? This can be done by an enzyme called the reverse transcriptase. So since the cell doesn't have enzymes that will replicate this RNA, and the RNA virus are unable to borrow the host cell enzymes, because there are no cell enzymes to copy RNA from RNA, so the reverse transcriptase will make a DNA version of the viral mRNA. So the use of the transverse transcriptase will make DNA from the RNA template to overcome these problems. Now this is the viral DNA is now will be able to replicated by the nuclei or the host enzymes, and will make another or a new virus, and the virus will be released and assembled by the capsid, and will be again released outside the cell to form a new virus. So the reverse transcriptase here will rescue the retrovirus or the RNA virus by making a DNA version of the RNA virus, in order for the host cell to work on it and to replicate. RNA virus will form what's called the cytoplasmic inclusions. This is in contrast to the DNA viruses, which will form the RNA, will form intranuclear inclusions. And there are some viruses, like the cytomegalovirus, that can produce both. It can produce both cytoplasmic inclusions and the nuclear inclusions. So these intranuclear inclusions and intracytoplasmic inclusions, when they can be referred as OLIs. So the OLI inclusion bodies are characteristic for the cytomegalovirus, in which there is intranuclear inclusion bodies and intracytoplasmic inclusion bodies. So remember OLI for the cytomegalovirus. How can the virus be transmitted from one patient to another, or to the patient? This can have two modes of transmission. There is vertical transmission and there is horizontal transmission. Vertical transmission is what happens when a mother has a virus, and she transmits this virus to the baby, like as we said, like the cytomegalovirus or the torch infection. It is one of the torch infection, like the rubella virus as well. So these viruses, when present in the mother, can be transmitted to their babies. So this is called the vertical transmission. Horizontal transmission can be the method for transmission of many viruses, like the air droplet infection. So airborne infection like the influenza will be transmitted by this way, or fecal-oral infection like the hepatitis A virus, or through the blood transfusion like the HIV or the hepatitis B virus. So it is a hematogenous infection. So these are all called horizontal kind of viral transmission. Different tests and the serological tests can be used for diagnosis of the virus. For example, we can just examine the virus by itself using the electron microscopy to examine the virus itself in the tissue or in the body tissue or in the body fluid. This can be called a direct viral isolation. So basically, what we see is for the virus is either we can see the virus itself or the viral antigen, or we can detect the viral antibody, or we can detect the DNA or the RNA of the virus. So this is, generally speaking, the commonest methods for diagnosis of the virus. The direct viral isolation by using electron microscopy. There is serological techniques for detection of the antigen or antibody, what's called the complement fixation test, in which there is can measure the reaction between the viral antigen and specific antibody, so that it can be used by adding RBCs or sheep RBCs into the viral antigen and check what is the amount of lysis or the hemolysis of these RBCs. This will give a clue about the antigen antibody reaction. This can be also referred as Coombs test. ELISA test and the radioimmunoassay test and reverse passive hemagglutination test. This can be used, for example, for hepatitis B surface antigen, in which there is a specific humoral response that can be detected in ocular fluids. PCR, in which we just examine or detect the genetic material of the virus in a human tissue, and by amplification of this genetic material, we identify the common organism, or we identify the invading virus. This can be the method of a choice. For example, in cases of affection of the retina by severe viral infection, as in acute retinal necrosis, or in case of chronic endophthalmitis, by taking a vitreous biopsy or a vitreous sample, we will be able to identify the virus inside this vitreous sample by the PCR. DNA viruses and the RNA viruses. So what are the DNA viruses and the RNA viruses? You need to know which one of them is a DNA and which one is RNA, because again, this can be asked in the exam. First of all, we have 4 viruses that belong to the herpes family. It's called the herpes simplex virus, the herpes zoster virus, the cytomegalovirus, and the Epstein-Barr virus. These 4 viruses belong to the herpes family. Then we have the human papilloma virus and the pox virus. These are the DNA viruses. The RNA viruses are the measles and the mumps and the rubella. So you remember that the famous vaccine of the MMR, measles and mumps and rubella. And finally, the HIV, or what's called a retrovirus. So as we use it too, we will know what are the common ocular manifestations of each one of these viruses and what are the important features of each one of them. Starting by the herpes simplex virus. The herpes simplex virus infection, there is 2 types of herpes simplex. We have the herpes simplex type 1, which is causing infection above the waist, while herpes simplex type 2 causing infection below the waist or the genital herpes. So what is the most common in ophthalmic practice is the herpes simplex type 1. Herpes simplex virus type 1 infection occur usually in early childhood, leading to the characteristic feature of blepharoconjunctivitis. Although the keratitis is rare in this stage, but sometimes these patients receive topical antiviral in order to protect or to guard against corneal affection. The virus become present in tissues or will reactivate later on under specific conditions. So when it reactivates, it can affect the cornea, causing the epithelial keratitis or stromal keratitis. Also, it can cause uveitis or retinitis. An examination, although the herpes simplex virus infection is clinically diagnosed, but if we want to make sure of diagnosis, then a culture or smear of the affected tissue, like the epithelium, can show an intraepithelial or intranuclear inclusion bodies, which appear eosinophilic and contain giant cells. So, a multinucleated giant cells with intranuclear inclusion bodies is something characteristic for the herpes simplex infection. Not only the active infection of the herpes simplex by the organism can cause the lesions, but also the immunity itself. So the immunity itself can cause a disease by reactivation of the antigen antibody reaction within the cornea. It's called the disciform or deciform keratitis. So the deciform keratitis is characterized by presence of the stromal edema overlying by the epithelial edema with keratic precipitates and rise of the intraocular pressure and what's called Weasley ring. Different characteristic features. It's just a hypersensitivity of due to viral antigen rather than invasion of the virus itself, because the viral envelope itself is highly immunogenic, leading to this stromal keratitis. So what is the triggering factors affecting that will initiate this condition? This usually occurs due to immune suppression. So usually the viruses are initiated or reactivated by the immune suppression or malignancy or chronic debilitating disease or chronic renal failure or the use of topical steroids. So these factors will impair the host immunity, leading to reactivation of the virus. Also, it can be triggered by hormonal changes or ultraviolet light. Stress and trauma can be also triggering factor for reactivation of the virus. So this is about the herpes simplex virus. Another virus that's from the herpes family is called the varicella zoster virus. So the primary infection of the varicella zoster virus is called shingles. It's called chickenpox. The chickenpox is a disease characterized by fly over the body, so it doesn't have a specific distribution. This is caused by the varicella zoster virus. It will last like about 2 weeks to 3 weeks, then it will improve, and the virus will become latent in the ganglia. So the virus is not over, or it is not killed, but it is present in the ganglia, specifically the thoracic, the cervical, the trigeminal ganglia. So what happens next is during periods of immune suppression or stress or illness or radiation, then this virus will reactivate. When the virus will reactivate, it will cause shingles. Shingles, or the herpes zoster, is characterized by severe pain involving specific dermatomes of the body that are supplied by the involved nerves or involved ganglia. So if the involved ganglia is the trigeminal ganglion, then this will result in the herpes zoster ophthalmicus. So what is the character of the herpes zoster ophthalmicus? It is present with lesions or a rash involving the mid-side of the face that is respecting the midline due to dermatomal distribution, and when it is involving the tip of the nose, this will result in, or most probably, that the cornea will be involved. The cornea will be involved by lesions are called pseudodendrites, so there are no true dendrites and there is no virus in the cornea. That's why the cornea will only treated by artificial tears. So there is no need for topical antiviral, but these patients will respond to systemic, or they will need systemic antiviral. So the reactivation can be due to concurrent illness or immune suppression or radiotherapy. And this is common in patients, in older patients, but if it is young patient, the HIV suspicion should be alarmed. Cytomegalovirus is one of the commonest infection on the earth. It is very, very common, but it is usually subclinical. So it doesn't cause any problems in about 90 to 80% of cases. And usually it is shed from the genital or urinary tract and become latent in the lymphocytes. So they infect the lymphocytes, and they can sometimes reactivate during pregnancy. And here come the problems. So although it is sometimes it can be asymptomatic when it is transmitted to the fetus, leading to asymptomatic infection, but sometimes it can cause congenital anomalies in the form of strabismus, chorioretinitis, microphthalmia, and hepatitis. So this is congenital infection with the cytomegalovirus. The cytomegalovirus infection in the immunosuppressed patient can cause cytomegalovirus retinitis and pneumonia. So the cytomegalovirus infection is one of the, or cytomegalovirus retinitis is one of the infections that present in patients who have HIV or patients who present with immune suppression to present with cytomegalovirus retinitis. So this is the most common form of retinitis in the immune-suppressed individuals. The Epstein-Barr virus, it is the causative agent or causative organism for the disease called infectious mononucleosis, which is present also with the rash and lymphadenopathy and fever, and have been also linked with tumors like Burkitt lymphoma and nasopharyngeal carcinoma. So this is what you need to know about the Epstein-Barr virus. And here we come to the adenovirus. Adenovirus, it is a very contagious disease that is characterized by transmission through the direct contact of the virus with ocular secretions. So that's why one of the main you need to know that you need to disinfect the applanation tonometer every time you use it with every patient, because this tip of the applanation tonometer can transmit the adenovirus from tears or from ocular secretions very easily from one patient to another. The adenovirus, as I told you, it is can be transmitted by direct contact. So by contaminated of hospitals or contaminated towels, and it is very common to be spread in epidemics in schools if a child has this adenoviral infection. So it is start with, there are different types or two main types according to the serotypes of the organism. We have the epidemic keratoconjunctivitis, which is caused by the serotype 8 and 19 and 37. And there is the pharyngeoconjunctival fever, which is caused by the serotype 3 and 7. So what is the difference between both of them? So it is epidemic keratoconjunctivitis. So the corneal affection is important here. So there is more incidence of corneal affection and less incidence of systemic problems. And these patients will present with preauricular lymphadenopathy, which will be precede the corneal affection usually, leading to that will aid the diagnosis. So these children usually, or the adults, present with a febrile illness with lymphadenopathy, followed by the appearance of follicular conjunctivitis and the subepithelial infiltrates. this annular infiltrates, and the sometimes can present with subconjunctival fever, hemorrhage. The other type is called the pharyngoconjunctival fever, caused by the serotypes 3 and 7, and this type has more incidence of systemic problems like fever and pharyngitis, as it's clearly evident from the name, but luckily it does have less incidence of corneal affection. So there is less incidence of keratitis, which will be the cause of dropping of the vision in these patients. So here is what's called the adenovirus. So just to remember, we have two types. Each type is caused by specific serotypes. And this disease is very, very contagious. Human papillomavirus it is a virus that will has the ability to infect the epithelial cells. So they will show proliferation. So if we examine these patients under the microscope, we will find that this patient will have lesion, that this lesion has a fibrovascular core. So there is a proliferation, finger-like projection of proliferation with a vascular core inside these cells. This is called a papilloma. So the human papilloma virus can cause this proliferation, leading to what's called a papilloma. Different types have been linked with different diseases. So we have the human papilloma virus. There are different human papilloma viruses. So we have the human papilloma virus 6 and 11 that they will cause a benign conjunctival papilloma like this, while the human papilloma virus 16 and 18 they will cause conjunctival dysplasia and carcinoma, leading to formation of conjunctival carcinoma like this. So the malignant change is caused by the human papilloma virus insertion of their DNA into the host genome. So since if the human papilloma virus inserted their gene inside the genes of the eye or inside the genes of ocular tissue, this will result in changes or mutation inside the ocular genes, leading to this type of malignant transformation. So this lesion or this malignant conjunctival dysplasia or carcinoma is caused by the specific types of human papillomavirus 16 and 18. The pox virus, it is a virus that is characterized by presence of a specific lesion in the eye that's called the molluscum contagiosum. Molluscum contagiosum, it is a virus caused by it is a disease characterized by presence of a waxy pale umbilicated nodules present in the lid margin that will shed the virus into the palpebral conjunctiva, or will shed the virus into the fornix, causing the presence of follicular conjunctivitis. So the follicular conjunctivitis here, it is the result of the virus which is shedded from the lid lesion of this molluscum contagiosum. So the conjunctivitis, it is the main agent. There will be multiple molluscums present in the lid, and usually this picture is present in children or in the immunosuppressed patients like HIV patients. These lesions are spread by direct contact or by contaminated towels or water, and sometimes it can be seen in the adults who are sexually active. Now we have talked about the DNA viruses. Let's talk about now the RNA viruses. First of all, we have the measles virus. The measles virus, it is RNA, belong to the family of paramyxoviruses. When the initial infection of measles occurs, this will lead to febrile illness characterized by presence of conjunctivitis. Sometimes, or the complications of this infection can lead to respiratory infection and encephalitis, and rarely subacute sclerosing panencephalitis, which can sometimes be associated with the chorioretinitis and maculopathy. So this is not a very common ocular pathogen, but it can be associated with severe infection with measles. The mumps infection, it is again belong to the RNA paramix of viruses, and with the initial infection, this will result in fever and parotitis or enlargement of the parotid gland. Also, it can cause orchitis and resulting in reduced fertility and pancreatitis and meningoencephalitis. For the eye, it can produce dacryoadenitis or inflammation of the lacrimal glands and paralysis of the extraocular muscles. So this is called the mumps virus, and what are the associations of mumps virus? The rubella virus is an RNA virus that is belonging to the Toga virus family, and it is present subclinically in about 80% of small children and 10% of adults. And the problem of the rubella that if it is infecting the mother in the first trimester of pregnancy, this will result in congenital anomalies due to spread of the rubella from the mother to the fetus through the placenta, leading to what's called congenital rubella syndrome. This can result in miscarriage or abortion or stillbirth, or the child will be born with congenital defects like microphthalmia, small size of the eye, congenital cataract. The retina will show the appearance of salt and pepper retinopathy with glaucoma and conductive deafness and heart defects. So these are manifestations of congenital rubella syndrome that occurs due to transmission of rubella virus from the mother to the child during the early pregnancy. Then we have finally the one of the most important viruses that is they tend to ask about it in the exam, which is the human immunodeficiency virus. So let's talk about it in more details. So the human immunodeficiency virus is subdivided into two types: the HIV type 1 and HIV type 2. And the problem of the HIV virus that it will infect the type of cells called the CD4 cells or the CD4 lymphocytes, which are responsible for fighting the infection. So the problem of the HIV itself is that it will infect the cells responsible for the immunity. This will result in depletion of the human immunity, leading to inability to withstand any trivial infection. So what is the structure of the human immunodeficiency virus? The human immunodeficiency virus is, as any virus, will be formed of a nuclear matter, which is in this case HIV, the RNA, surrounded by a capsid, and it has surrounded by an envelope, and it contains some enzymes like the reverse transcriptase. As we said, that the reverse transcriptase is important for replication of the virus, and then it will be surrounded by some on the top there will be some glycoproteins or HIV glycoproteins. The HIV virus will be can be killed by strong acid or resist strong acid or strong alkali. Let's now see or have more in-depth details about the structure of the HIV virus. The HIV virus consists of some structural genes. These structural genes will code for different proteins, as we will see now. First of all, or the first types of genes are called structural genes. So what are the structural genes? The structural genes can be classified into two types: the GAG genes and the envelope gene. The GAG gene will code for a protein called the protein 55. This protein 55 will cleave into protein 17 and protein 24. So protein 17 and protein 24 are the result of the structural gene formation. The structural gene will result in formation of GAG gene, or the protein that will form the protein 55. This protein 55 will divide to form the protein 17 and the protein 24. And also they have the envelope gene. The envelope gene will code for a glycoprotein enclosing the viral particle. This glycoprotein will form the glycoprotein 120 and the glycoprotein 41. So the glycoprotein 120 and the glycoprotein 41 are the result of envelope gene coding. So you may wonder, why do we study this? Because some of these proteins are used for identification of the HIV infection. So when we want to diagnose HIV infection, we can use these proteins or glycoproteins in order to identify an active infection. Then there is regulatory genes. The regulatory genes are used for stimulation of the viral transcription and cause proliferation of the adjacent healthy cells as B cells and Kaposi sarcoma. So these regulatory genes are used for enhancing the proliferation of the virus. Here you can see the glycoprotein 120 and 141. So again, the regulatory genes are the genes that are responsible for viral transcription and proliferation. The polymerase gene, which codes for the reverse transcriptase enzyme. So the virus has a gene that's called the polymerase gene that will result in formation of the reverse transcriptase that will transcribe formation of the viral RNA to DNA. And this DNA will be able to be incorporated into the host genome. As we said, that the viral RNA by itself will not be able to invade the host nuclear matter. So these are the important genes present in the viral, the virus itself. So how can the virus infect the human, the cell? So what is the pathogenesis? The HIV life cycle, it is the same like any viral cycle, but the only difference that they target specific cells or the CD4 cells. So the HIV will attach itself into the cell wall of this of the CD4 cells. Then it will penetrate inside. Then will introduce its RNA that, under the effect of the reverse transcriptase, will form the DNA. The DNA will control the nuclear material of the nucleus in order to copy the viral DNA, the viral itself. Then the virus will be released from the cell, and then the virus will be replicated, leading to going out, or the cell will burst in order to form forming different viruses that will infect other CD4 cells. So as the infection, or since the infection, the patient will have increasing the viral load and decreasing CD4 count, because every time the virus infects the CD4 cell, it will target its metabolism in order to get out from the cell, leading to rupture of this cell, leading to replication of the virus and decreasing the number of CD4 cells. There are different methods for HIV transmission, like sexual contact, like pregnancy, childbirth, so it can be vertical transmission from the mother to the baby, or horizontal transmission by sexually or by injection of the drugs, or blood transfusion, or occupational exposure for the medical personnel, or blood transfusion and organ transplant. The stages that through which the HIV pass into 3 stages mainly. The first stage, or the acute infection, till the seroconvergence. So what happens when a patient takes or is infected with the HIV? Sometimes it can be asymptomatic, and other times it can be cause acute HIV infection, which is present as any viral illness infection, present with high fever, present with weight loss, lymphadenopathy, pharyngitis. So this happens from the day one of infection, and as the viral load, here is the viral load increase, as it is increased, and the CD4 starts to decrease, as you can see here. So as the virus is starting to replicate, and then at this point, at about in the first 12 weeks, the body is containing very high amount of the viral cells, so the patient is very infectious. So what happens now? This is the period in which there is called the seroconvergence. At about 12 weeks, there is a seroconvergence, meaning that the patient's blood become positive for HIV antibodies. So during the first 12 weeks or the first 3 months, when we test for the antibodies, sometimes it become negative. So it is not wise to detect or to diagnose the HIV by testing for the antibody in the first 3 months, because at that time the viral load is still increasing and the antibody is still not present. When it reach it become the highest level, or at 3 months, then the HIV antibodies will become formed, and so this will be the first stage, or the acute infection, or the seroconversion. Then the immunity try to recover and try to control the infection. So there will be initial rise of the CD4 count, and there will be the immunoglobulins will fight the infection, causing the decreasing the viral load. So this will be the second stage, or the latent infection. And this stage, the patient will appear as if he is asymptomatic, or the patient will be present with the patient will appear normal with no apparent infection, as he has a good CD4 count, or reasonable CD4 count. But as the years pass by, the CD4 count will gradually decrease and the viral load will gradually increase, until finally reach the third stage, in which there is symptomatic infection. At this stage, the patient will have some infections due to decreasing the immunity, because of decreasing the CD4 count and increasing the viral load. And then finally will be the stage of very severe infection, or the stage of human immunodeficiency, or AIDS. So the stage in which the patient will have a terminal disease that results from immunosuppression. So this curve can show you that there are different diseases according to the CD4 count, starting from 500, showing the herpes simplex, herpes zoster, fungal infection. At 400 can show Kaposi sarcoma. At the CD4 count of 300, show leukoplakia or tuberculosis. 200 can show cryptococcosis and toxoplasmosis. At 100 can show cytomegalovirus and lymphoma. So this is the curve in which the patient will show different manifestations in respect to the number of the CD4 count. So the CD4 count will be the important determinant factor for the current clinical condition of the patient. There are different systemic conditions. Without first, what concerns us more are the ocular manifestations of the HIV. So it can be present with HIV microangiopathy, which is the same like or appear like a retinopathy, the same like diabetic retinopathy, present with microaneurysms, hemorrhage, and cotton wool spots. And it's very common in HIV patients. Opportunistic infection can be viral, can be parasitic, or fungal infection, or bacterial infection. Can be present with tumors like Kaposi sarcoma, lymphoma, and squamous cell carcinoma, or neuroophthalmic disorders such as optic neuritis, optic atrophy, cranial nerve palsy, cortical blindness. So these are the ocular manifestations of the HIV when the CD4 count decreases. So how can we diagnose the HIV? We have 4 mainstays for diagnosis of HIV infection. This can be done by culture, or by detection of the antigen, or by detection of the antibodies, or detection of the nucleic acid. So for the culture, we just can co-culture the HIV organism with the normal lymphocytes. And by detection of the virus itself, we can know that this patient has HIV infection. Or we can detect the viral antigen. As I told you, that the antigen will be the most rapid method in order to detect the HIV after the infection. Usually, it peak the protein 24, as I told you about. The protein 24 will be present at 2 to 3 weeks after infection. So if we want to diagnose the HIV immediately after the infection, the detection of the antigen will be the appropriate method. The antibodies can be used after the 24 after the 40 the first 3 months. So this lucid interval of the 3 months will be the period that elapses between the active infection and the appearance of the antibodies like the IgG or IgM in the blood. So this is called the seroconversion. So how can we detect this antibodies? This can be done by the ELISA or the Western blot technique. Can detect the IgG or IgM against the envelope protein and the structural proteins that's formed by the protein 55. So the protein 55 and the envelope protein will produce immunoglobulins against them, like IgG and IgM, and these are the measured antibodies after the period of 3 months and can be diagnosed by the ELISA and Western blotting technique. Finally, the nucleic acid can be detected by the PCR technique. So these are the methods for diagnosis of HIV infection. So is everything clear about the viruses? Okay. So let's now talk about the fungi. So starting by the fungal characteristics and how can we classify the fungi. What are the fungal characteristics? In contrast to the bacteria, the fungi are eukaryotic cells. So these cells, the nucleus has a membrane and it has organelles inside the cell. The same like the human cell and the animal cell, so it's called a eukaryotic cell. They contain both DNA and RNA, and they can reproduce sexually. And they can be classified according to their metabolic form or the metabolic needs into two forms, either parasitic or saprophytic. So what is the difference between both of them? The saprophytic, or let's start by the parasitic. So the parasitic, as any parasite, it needs a living tissue in order to multiply, and it depends on the tissue and on a living tissue in order to for energy production, for a source of food. So like for example, the fingernail fungal infection or the tinea, they will just need some living tissue in order to live or to survive. On the other hand, there is the saprophytic organisms or the saprophytic fungal infection. They need dead tissue. So these kind of fungi, they live on dead animals and they live dead plants and dead tissue in order to provide them with a source of food and the source of energy. So again, that's the difference between the parasitic and saprophytic, is that the parasitic depending on living tissue, while the saprophytic will be depending on dead tissue. The fungi can be classified into three kinds. The first one is called yeast, and the second type is called filamentous, and the third type, it is dimorphic. So what is the difference between all of them? The yeast is a unicellular kind of fungus. So the fungus is consisting of only one cell. Single cell is that what makes the fungus. And the example of this are the Candida albicans and the Cryptococcus neoformans. The second type is called the filamentous, in which there is branching filaments. As you can see here, there are multiple branching filaments. These branching filaments, the single branching filament is called the mycelium, and all these or the numerous filaments are called the mycelia. So the mycelia is the characteristic feature of filamentous fungi, and the example for this is the Aspergillus, which is responsible for aspergillosis, and the Mucorrhizae, which is responsible for the mucormycosis, and the Actinomyces israeli. As we said before, it can be considered also as a fungus. The dimorphic fungi is exhibiting the features of both yeast and filamentous fungi. So it is a mixture of both yeast and filamentous, meaning that they can present as yeast in as the difference can be evident by changing the temperature, meaning that in lower temperature they can present as filamentous fungus, as here as here, and at higher temperature they can present as yeast. So it is present can present with both features. The example for this is the organism responsible for presumed ocular histoplasmosis, which is called Histoplasma capsulatum. So here are the fungal classification: yeast and filamentous and dimorphic. Let's now review each one of them. Before we go through each individual fungus, let's know what are the general diagnostic criteria for the fungi. The stains for yeast and filamentous by the gram-positive or by the gram stain can be gram-positive. The culture is on Sabaro medium, and immunofluorescent assay also can be used for diagnosis of fungal infection, and the PCR to detect the fungal DNA, specifically in case of endogenous fungal endophthalmitis, in which we take a vitreous biopsy in order to examine for the Candida infection. So talking about the Candida. The Candida is a unicellular, as it is a yeast, oval organism that reproduces by budding. It is normal commensal of the GIT system, genitourinary system, respiratory tract, and it is the importance in the eye that it is the most common cause of endogenous fungal endophthalmitis. This disease occurs in immunocompromised patients, like patients on chemotherapy or patients with renal transplant, or HIV patients, in which there is fungal infection of the eye, and the eye appears relatively quiet because of decreased immunity, and present with this characteristic pattern of what's called cotton ball appearance. So the cotton ball appearance present in these patients due to Candida infection. The most common cause of, or the most common source of this Candida is the contamination of the venous catheter tip. So when we introduce a venous catheter to these patients, and this catheter is contaminated with the fungal infection, this will result in fungemia, and the fungus will reach the eye, causing this character or this appearance. And this means that usually these patients are terminally ill, and usually these patients will die within like 1 year or 1 year maximum. In order to identify this fungus, then we need to take a vitreous biopsy, and we culture it on the Sabaro glucose medium or the blood agar. They show a characteristic dome-shaped creamy white colonies, as you can see here. So this is the Candida albicans, and this is the first form of the yeast fungus. The second form of yeast is called the Cryptococcus neoformans, and the first discovery of this organism was in HIV patients. So if you wanted to know how was the HIV discovered, then these patients was discovered by having a strange fungal infection of their lungs that comes through inhalation. This fungal infection is called the Cryptococcus neoformans, and it was found that these patients who have this fungal infection have severe immune suppression, and hence the HIV was discovered. So the Cryptococcus neoformans is a disease affecting the severely immunocompromised patients, leading to meningoencephalitis So again, the fungal infection is usually a disease affecting the immunocompromised patients. The Aspergillus fumigates are a kind of filamentous fungi that is found in the decomposing or the dead plant debris. When the plant is becoming dead or debris, their debris is forming spores, or the Aspergillus is present on there and on these plants, and it will form spores. And these spores, if inhaled, this will result in aspergillosis. So aspergillosis again is an opportunistic pathogen, so it will cause infection if the immune suppression is compromised or if the immune system is compromised. This will result in conjunctivitis, keratitis, fungal keratitis, endophthalmitis, and granulomatous orbital inflammation. And also it can become more invasive in patients who are immunocompromised. So this is called the aspergillosis, and this is one of kind of the filamentous fungi. Then the other form of filamentous fungi, it is called the mucorrhea, and the mucorrhea is present in the soil, present in the air and ventilation system, and in the nose and pharynx. It depends on iron for their growth, and they can be detected by stain by the Gomori methylamine silver, hematoxylin and eosine, and periodic acid chaff. So what happens when a patient inhaled the mucorrhea spores? Actually, if in the normal individual, the mucorrhea is a weak organism, so it can be easily destroyed by the macrophages. So if a normal patient or a normal individual, the macrophages will destroy the mucorrhea spores, but this is not the condition if there is acidity. Meaning that if a patient has acidic environment, then the phagocytosis is compromised. This results in infection, leading to mucormycosis. And this mucormycosis, since it is present in acidic medium, it is common in the non-ketotic diabetic ketoacidosis. So this infection is very common in end-stage patients with diabetic ketoacidosis and chronic diseases or metastatic neoplastic diseases in which there is acidic medium. So usually you will find these patients in the intensive care because these patients are terminally ill. I want to stress that this disease is characterized by presence of black eschers or black eschers. These black eschers or black eschers are characteristic for the mucorrhea and characteristic for the mucormycosis. And these patients will need intravenous amphotericin B for fighting this infection. Another form of the filamentous fungi is called the Actinomyces israeli, and it is anaerobic or microaerophilic, so it doesn't need air that much, and it can be cultured on the brain-heart infusion agar. This is the same culture medium for Haemophilus influenza, and also can be identified by brown and green gram staining. They will show yellow-white colonies on the agar. This is because they tend to form sulfur granules. These sulfur granules can even be seen clinically because the sulfur granules can be expressed as this disease, as we said, can cause canaliculitis. So the canaliculitis is, or the canaliculi are filled with sulfur granules. So when we compress on the canaliculi, the sulfur granules can be expressed from the pancreas. So this is called the actinomyces and can cause canaliculitis, and usually it is responsive for penicillins and cephalosporins. Histoplasma capsulatum, it is a fungal infection or a fungus that is present in dimorphic form. So it can be present as yeast and present also as a filamentous fungus. Sometimes they ask in the exam about the endemic areas. So the histoplasma, it is very important to know that the histoplasma capsulatum is endemic in the Mississippi area in America. So it's about 70% of capsulatum. So remember the word Mississippi for the histoplasma capsulatum. And the transmission is by inhalation. So the mycelia or the spores are inhaled, leading to mild febrile illness, or sometimes it can be asymptomatic. So how can the eye be affected? Well, when the organism reaches the blood, then it can reach the choroid. So does it can cause active choroiditis? The answer is no. It is not common to cause active choroiditis. So how can it affect the eye? Usually by immune response, meaning that the disease that is caused in the choroid by the presumptive ocular or the ocular histoplasmosis, it is an immune mediated. And the disease is called the presumptive ocular histoplasmosis syndrome, characterized by the multifocal choroiditis with the formation of CNV. So it is immunologically mediated, and in the individuals exposed to the fungus. So the fungus itself will induce immune reaction rather than active invasion, leading to presence of multiple atrophic chorioretinal spots and scars, and can also complicate by choroidal neovascular membrane. It is sensitive to amphotericin B and ketoconazole, and as we said, it is a dimorphic fungus, so it is at 26 degrees present in the mycelial form and or the filamentous form, and if we increase the temperature to 37, it is present in the yeast form. So this is one of the diagnostic features of the ocular histoplasmosis, and also it can be cultured on the brain heart infusion agar. Any question in the fungi? Okay, so let's talk now about the parasites. So I guess that you may find this lecture somewhat interesting because it has some clinical components rather than the other basic stuff. So the ocular intracellular parasites are the chlamydia. It can be chlamydia or a protozoa. The protozoa can be either the toxoplasma and acanthamoeba. So let's start with the chlamydia. Chlamydia sometimes can be considered a bacteria, but they lack the cell wall. This is important and often in the MCQ. So the chlamydia can be considered as a bacteria without cell wall, or also they can be considered as an obligate intracellular parasites because they cannot grow on a normal medium, and they have to be always inside the cell. They are obligate intracellular bacteria that can grow only on eukaryotic host cell. So although other bacteria can be taken outside and put it on agar like blood agar or chocolate agar and show and demonstrate the growth of the organism, but the chlamydia can't do so because it is an obligate intracellular bacteria. They need a living cell in order to live inside. However, they can grow well in the cell culture or in the McCoy medium. The McCoy medium will be the specific type of medium that grow the chlamydia. And they contain both DNA and RNA and require some host-derived ATP, so they require some ATP and glucose from the host in order to survive and replicate. And they divide by binary fission. There are several types of chlamydia. What concerns us here as an ophthalmologist is what's called the chlamydia trachomatis. The chlamydia trachomatis itself has several serotypes. Every one of them is linked to specific disease. So Trachomatis serotype A and B and C have been linked to trachoma. So this is the causative agent for trachoma, which is an endemic disease in some areas in the world, and present more in developing countries, causing cicatrization of the conjunctival and the corneal surface. The chlamydia trachomatis serotypes from D to K cause adult inclusion conjunctivitis, which is a sexually transmitted disease characterized by presence of follicular conjunctivitis. And finally, the serotypes L1, L2, and L3 is characterized by a venereal disease called the lymphogranuloma venereum, characterized by presence of lymphadenopathy and granuloma. So how to diagnose the chlamydia? Chlamydia can be diagnosed by GEMSA stain. So we stain the smear with GEMSA, and in order to find a basophilic intracytoplasmic inclusion bodies. This is also asked in the MCQ. Basophilic intracytoplasmic inclusion bodies is characteristic feature for the chlamydia infection. Also, as we said, it can be cultured on the McCoy cells. ELISA can be used also for detection of the inclusion bodies, antibody detection in the serum and the tears, antibody against the chlamydia, and the treatment can be initiated by the tetracycline, erythromycin, rifampicin, azithromycin, and sulfonamide. So the erythromycin and the azithromycins are now the treatment of choice. The second parasite is called the toxoplasma. And toxoplasma, again, it is an obligate intracellular parasite. So the Toxoplasma gondii cannot live outside the infective form, or what's called the trophozoite. It cannot act or cannot live outside a living cell. That's why it's called obligate intracellular parasite. It has a definitive host, which is the cat. And the cat will pass its fecal spread of the sporocyst or the sporulated form, in which it becomes a cyst in the soil, and then contamination by this oocyst will result in infection of the intermediate host, like the human or like the animal. So the infection can be done by ingestion or inhalation of this sporocyst, either through cooked meat or by inhalation. Or if it is present in the mother, then the infective form can pass directly from the mother to the fetus, either in the early pregnancy or in the late pregnancy, which will present with different clinical pictures, leading to vertical transmission. So a vertical transmission, if an antibody negative mother is infected during the pregnancy, this will result in active infection, and this infection or this antigen or the infective form will pass to the fetus, leading to congenital toxoplasmosis. So usually it is asymptomatic, but sometimes it can present with a toxoplasma scar, which is present with punched out edge and variable pigmentation, or it can be present with active lesion as active chorioretinitis, or sometimes it can be present with both pictures. So there is active chorioretinitis and there is a scar here. So talking about the life cycle of the chlamydia, of the toxoplasma. So the cat is the definitive host. So the cat will pass the oocyst through their feces, and as we said, the cyst is a resistant form, so it can stay on the soil for a long time. When like a man ingest it in the soil or has ingested the oocyst by accident through an object contaminated with the soil, or if it is a baby, for example, that ingests something contaminated with the soil, this result in this oocyst will hatch, causing formation of the active form or the tachyzoite, which will invade the retina or causing the active chorioretinitis. Or sometimes this oocyst will be ingested by the intermediate host, and this will result in, if it is ingested by the definitive host, this will result in that the definitive host will possess the active form again. Or sometimes they can go for intermediate host, so the oocyst can be ingested by cows or pigs and being cooked is not cooked well, and the man ingest it. This will result in that the man will be infected. So this is simply the life cycle of the toxoplasma. Toxoplasma can be diagnosed by several methods. The PCR will be the gold standard, or will be the definitive way of management of diagnosis by detection of the IgG and IgM of the against the toxoplasma in the samples from the eye, like the aqueous humor or the vitreous. However, this is not usually needed because the diagnosis can be done clinically by the appearance of the active chorioretinal lesion or the chorioretinal scar, and treatment can be done for active cases only, not for the scars, and in specific precautions. We will. This is not our topic now. So the treatment of toxoplasma can be done by several drugs like pyrimethamine, sulfadiazine, clindamycin. And sometimes these patients can need steroids to decrease the intraocular inflammation. The acanthamoeba, finally, it is the acanthamoeba. It is a kind of protozoa. So it is like an amoeba that is present in water in water resources like the public water supplies, like the swimming pools and the hot tubs, the freshwater ponds, lakes, and bottled mineral water and soil. So it can present in various forms of the water supplies. So how can it contaminate the eye? Usually they contaminate the eye by it can cause severe corneal ulceration and inflammation, most commonly associated with contact lens wearer. So if the patient is contact lens wearer and he just doesn't use the contact lens solution or wash the contact lens with the with running water, or if he is a farmer, for example, and using the using water bombs or using public water, then this the acanthamoeba can be present in the water, can infect his eyes, specifically his contact lens, his eyes cornea, leading to the characteristic picture of acanthamoeba keratitis. So the acanthamoeba keratitis first infected the epithelial surface, causing the appearance of epithelial pseudodendrites, which is sometimes mistaken as epithelial keratitis, but the characteristic feature that it will infiltrate the corneal nerves, leading to what's called radial perineuritis or radial neurokeratitis, which will cause the patient severe pain. And also it can cause stromal infiltration and the ring ulcer due to the collagenase activity or the collagenase enzymatic activity of the organism. There are different methods for diagnosis of acanthamoeba keratitis, either by visualization of the acanthamoeba cysts in the hematoxylin and the eosin from normal tissue or from tissue biopsy, or by periodic acid shift. Again, we can visualize the acanthamoeba cysts, or by James stain, can show also the acanthamoeba cysts, and the calcoflower white stain also can show the acanthamoeba cysts. The culture here is one of the most important things that is asked in the exam, as this organism is cultured on a specific type of medium called non-nutrient agar seeded with dead E. coli. Because this E. coli is the food of the organism. So when you put a dead E. coli in this agar, the acanthamoeba will feed on this E. coli, leading to it will proliferate. So it will form these colonies, and you will be able to diagnose the acanthamoeba castellani, for example. So this is called the culture. So the culture media here is non-nutrient agar seeded with E. coli. However, away from the microbiology, the gold standard for diagnosis of acanthamoeba is the confocal microscopy, which is able to visualize the acanthamoeba cyst on living human corneal tissue. So we don't need to take a biopsy, or we don't need to take a smear from the cornea. And also PCR can be used for identification of the DNA or the genetic material of the acanthamoeba. So these are what's regarding the parasites. and the chlamydia, and the third thing that we talked about, I don't remember, the toxoplasma. Yeah. So any question regarding the chlamydia and toxoplasma and the acanthamoeba? Okay, just let's talk now about the sterilization and disinfection, the methods used for sterilization and disinfecting the ophthalmic instruments and that are used for routine practice, since we are talking about the microorganisms, bacteria and virus and fungi. So we need to take care how to not to aid the transmission of these microorganisms. So this can be done by sterilization and disinfection. The first question that will come to our mind, what is the difference between the sterilization and disinfection? So the sterilization is a broader term or a much more wider term that will mean that we destroy all the microbes. So this is our ultimate goal, is to destroy all microbes. We don't want any living organism on the surgical instrument, for example, or for the intravenous catheter, for example, or the intravenous fluid, or dressing, or eye drops. So we need to, the sterilization is just a destruction of all living forms of the microorganisms. So how can we do so? What are the methods that can enable us to do killing of all these microorganisms? There are different methods. First of all, the wet heat autoclave, or dry heat, or the ethylene oxide, or the gamma radiation. So both of them or all of them has some principles. For example, the wet heat autoclave, in which there is exposure to steam at high pressure. This high pressurized steam will produce a very high temperature. Then this temperature will be able to kill the microorganisms. Then the materials are dried, and then high pressure vacuum pumps reduce the sterilization time. So in decreasing sterilization time, sometimes it can be a very important issue, because like look at here, the time the wet heat autoclave takes about 120 minutes, which if we talk about surgical instruments, it is too long time to sterilize between the re-sterilization cycles will take too much time. So this will cause lag in the operation room. Dry heat can be used for the instruments that may lose their sharp edge through steam or powders and oils. So if we wanted to sterilize a scalpel or a sharp instrument that we are afraid that they will become blunt with time, if we are using the steam, then we use the dry heat. Or if we want to sterilize powders or oils, then the dry heat will be of a choice. So this can be done by a fan-assisted drying oven heated up to 160. So the dry heat have higher temperature than the wet heat, and this usually takes about several hours. Ethylene oxide gas, it can act as a sterilizer below air temperature, so that it can be used for instruments that are susceptible to heat, like plastic and rubber. So plastic and rubber will melt down or will lose its form if it is sterilized by high heat or by temperature. So we use this ethylene oxide gas, and then the equipment should be aerated or allow the air to pass inside to get rid of the gas. And this can be done for 24 hours to 48 hours. And the gamma radiations can be done for industrial sterilization, so it is not used for the routine ophthalmic practice, because it needs a high-tech equipment and expensive equipment, and it can be used for the industrial sterilization of disposable medical items. The disinfection, or the contrary, the disinfection is another form of getting rid of microorganisms, but the goal of disinfection is to destroy the pathogenic microorganisms. microorganisms are pathogenic. Not all of the microbes are can cause harm to the individual. So the disinfection is only targeting the pathogenic microbes, not everything. So for example, the prior to surgery, the skin is disinfected but not sterile, meaning that if we put like povidone iodine prior to the surgery, or we disinfect the skin around of the eyelids and the surrounding skin by putting just the povidone iodine, this is not a sterilization. This is a disinfection. We just kill the pathogenic microbes. So what are the methods of disinfection? We have the phenol-based solutions, like for example formalin in ethanol. This can be the different organisms can be susceptible for this solution. It can kill pathogenic bacteria, the spores, the fungi, and the viruses, and usually this can be taken for hours. The glutaraldehyde can be effective against vegetative bacteria, fungi, and viruses, and they can be used for metal instruments and the glass lenses. So it can be used for the disinfection of the Goldman applanation tonometer tip, and also can be used for hours, or can be effective for hours. The ethyl alcohol, 70% in water, or like the normal, the sterilium that we are used in the operation room for our hands, it's used for killing the non-sporing organisms, but not in the presence of body fluids, and active against viruses, but not the adenoviruses. And the time it can be active in about 15 seconds or 30 seconds in order to be effective. Iodine in alcohol, used for bacteria but not the spores, or cannot be cannot be effective against the spores. It can kill only bacteria, but the problem, it is irritant. So when we are washing our hands with povidone iodine before the surgery, sometimes, or some of us can feel some irritation, and they need to rewash it after the surgery, and it takes a few minutes in order to be effective. Chlorhexidine and the hexachlorophene, then this is effective against most of the skin pathogens, and the hexachlorophene is toxic if absorbed over large areas, and it can take only a few minutes in order to be effective. So these are the methods for disinfection. Some are phenol-based, such as formalin in ethanol, the glutaraldehyde, the ethyl alcohol in 70% water, the iodine in alcohol, the chlorhexidine, and the hexachlorophene. So these are the disinfectant and the sterilizer. Any questions in them? Thank you very much for your attention. I hope that you enjoyed the lecture, and I hope that we have been able to cover the microbiology curriculum for your exam. Thank you for your attention again, and tomorrow we will have another lecture. I just still didn't decide if it will be genetics or pathology, but anyway, one of them will be discussed tomorrow. And hopefully that we will finish the course next week with the remaining lecture and with the revision, so that we will come to the final revision. Thank you very much, and we'll see you tomorrow, inshallah. And good night.